Hi, today I wanted to talk about a few things that are bubbling, and this will be in lieu, or at least before we do the series on contracting and what might help you in your practice to get better rates to allow you to provide care to your patients. So the first thing is really the Medicare physician fee schedule. We talked about some of this last time, but the fee schedule has come out, and that was really a preview of what might come forward. Luckily, we have until September 9th to comment, and there already are some great APTA resources on commenting, but AOPT and others will be doing, including private practice section, will be doing comments as well, or at least providing folks the opportunity to focus on value-based care for the AOPT side and other cuts and just payment rates generally, as well as some coding and other technical payer issues or payment issues in their comments that individual members can send. So the first thing is to recognize that there is a cut in this fee schedule. We're really tired of these. But it is a 2.8% cut, and hopefully what we'll do is we'll be able to comment to CMS, the Centers for Medicare and Medicaid Services, the agency that oversees the fee schedule, and let them know what this will do to AOPT and other practices. It's like I said, about a 2.8% cut. It's actually blunted to some extent by a few other things that are in the fee schedule. But before we get into those, it also discusses the Medicare Economic Index, which would be something that would peg the changes to inflation. We're very supportive of that, and it would be great if folks are able to comment on that. There's a solicitation for comments on that issue. And so, tying it to inflation makes a ton of sense, especially with the inflation that we've experienced recently. Additionally, there's a cap on the use of the KX modifier. So that threshold is going to be $2,410, and that's a 3.6% increase, as well as for both PT and SLP services. And then in 2024, that was 2,330. So again, it's a little bit of an increase there. PTA supervision, it's good news here. So as you probably know, there is a piece of legislation that AOPT and others are supporting called the Empower Act. And really, this is probably the reason that CMS has made this change. Currently, Medicare permits general supervision of a PT assistant by physical therapists in all settings, except for outpatient private practice under Part B, which requires direct supervision. We encouraged CMS through that legislation and through regulatory advocacy to use their authority to allow for the reversal of that. And CMS listened, right? They're proposing to change the regulatory requirements for OTs and PTs who are enrolled as suppliers in Medicare as PTs in private practice, to allow for general supervision of their PT assistants to the extent permitted under state law. So this is a really complicated area, but if your state allows for that direct supervision, for that general supervision, then it's likely that if we're able to keep this in the final rule, that will be available going forward. So that's great news. There's also something that I think is going to have a real impact on practices as well, and that is the certification of therapy plans of care with a physician or an NP order. And so this is something that is outlined in the REDUCE Act, another piece of legislation that was moving along through Congress, still is moving along through Congress. And what they're proposing is to amend the regulations at Section 424.24C, not that matters, but basically what it allows for, or would allow for, is a signed and dated order or referral to be sufficient to demonstrate the physician NP's initial certification of the plan of care. So that's really good, right? You don't have to wait then on a plan of care that might be sitting on a physician's desk or in someone's offices in order to provide that care and hopefully get paid for that care, delaying the patient from getting the care and getting in the door as quickly as they can. And there are some specifics about this that I encourage you to read a little bit, but essentially it's a really good policy that we want to keep in the final rule. And again, comments are solicited on this. There are no time restrictions in the regulation or specific proposals to modify the regulation. However, APTA recommended that physicians and NPs have 10 business days from the date of the receipt of the plan of care to modify that plan of care through the REDUCE Act. And CMS is unsure if that is sufficient time to review the plan of care. So there's a few wrinkles like that one. CMS is also soliciting comments on whether there should be a time limit on the order/referral when it's intended to serve as the initial certification. We, I think, would support a 90-day time frame, and that's what CMS is requesting comment upon. So one other thing that was in an earlier video that I think is important to notice is that there is revaluation of certain codes that are commonly used by PTs. And those 19 codes are in the physical medicine and rehabilitation code family, and really are a result of great advocacy on the part of APTA to get the RUC, the Relative Value Update Committee within the American Medical Association, to reconsider recommended RVUs, relative value units, for these codes. And the net result is that 16 of the 19 codes had a slight increase in the PE expense, and 3 of the 19 codes had a slight decrease in PE. There's not that much use of at least one of those codes that had a decrease. And so overall, this is really good news. And I think, we certainly want to keep those increased valuations. And there's actually a proposal from APTA to make them even higher, and recommend that higher level of PE to the RVU analysis be adopted. That's what CMS said they wanted anyway, but somehow they didn't agree with their earlier recommendation. And so we'd like to lock them in, or at least encourage them to reconsider that and make those PE values even higher. Some other things that folks might really care about, there is some lock-in on CMS's part with telehealth. So those flexibilities will really only continue until the end of the year unless Congress acts. The problem is that that's really expensive. The Congressional Budget Office has scored an extension of that flexibility very high, and so we're trying to look for money. And something might happen in the lame duck once the election is decided. But right now, CMS is doing all that they can in terms of changing or providing that flexibility, which is really they can't do anything. So that's reflected in the fee schedule as well. We'd like to see that continue, but I do know that telehealth is a higher priority for some folks than many PTs. The quality payment program is, I think, something that AOPT cares very deeply about. Others care very deeply about it as well. But really, with the home of the clinical practice guidelines, this is where we really are able to start seeing a linkage between good practice and payment. And I would argue that the quality payment program to date for physical therapy has been I won't even say it's a mitigated disaster. It's a pretty unmitigated disaster in terms of the juice being worth the squeeze. And so many PT practices have spent a lot of money to try to implement MIPS. And unfortunately, they just haven't received any real funding back from the program. There's certainly been some bump ups, but I've never heard of any practice that really made money by scoring really high. They may have made more in terms of their Medicare revenue, but the cost of setting up the systems to be compliant is really makes it really challenging to justify. So, however, there were 9 new measures that were added, and 11 were removed. None were related to PT, which is good. There are no changes to the promoting interoperability category. There is a new MVP, not starting in PT, but ophthalmology, dermatology, gastroenterology. A few others are getting new MVPs, and then 2 neurological MVPs are going to be melded into 1 MVP. And then there is going to be a shift in the threshold policies as well. Discussions of advanced APMs and Medicare savings proposal. And then the cost measure scoring is going to shift too. Finally, probably the most important for musculoskeletal care is the rehabilitative support for musculoskeletal care MVP, which there was a comment upon by APTA and its components. Within this structure, there is a proposed to include 1 additional MIPS quality score and 4 qualified clinical data registry scores, or QCDR measures. Those will include urinary incontinence, as well as patients suffering from a neck, upper extremity, back, or lower extremity injury who improve pain. And then there's going to be an improvement activity, which is COVID-19 vaccine achievement for practice staff. There is no change in the cost measure that was proposed for low back pain, and so that will continue on in this MVP. So Sadly, I think that this is pretty much unworkable, this MVP, for most practices, because many of the scores and the measures are unachievable. And so we really want to try to modify this as time goes forward to make it more practicable. Very in the weeds, but very important, I think, for folks to recognize that there's at least one continuation of the MIPS program in terms of this MVP, MIPS value program, that will apply to PT. It's just we have to really continue to lobby CMS to get them to make it functional within the PT space. One other thing I wanted to discuss is, and certainly is on many practices' minds and folks who work there, is a shift in UnitedHealthcare's policy and Optum's policy on prior authorization. And so in late July, there was a publication of a notice, really not a new policy, showing that United was going to implement prior authorization for basically all of the services that PTs would provide after the first visit in practices. There are a few exceptions like home health care, and in facilities there's coverage here as well. However, there is not a requirement for out-of-network folks, and so it's something that's going to affect a lot of UnitedHealthcare payer services. Very frustrating. APTA has been pushing back on this. We're going to do a letter writing campaign. We're going to try to continue to advocate with United to try to at least delay the implementation of this policy. They gave 1 month for everyone across the country to modify their structures to allow for this prior authorization after the first visit. Additionally, Optum, I would argue, made it worse by creating an even more complex form that everyone will have to fill out in order to achieve those prior authorizations. All of that information that's critical, we believe, is already in the plan of care. So it's absolutely a paperwork burden without any benefit to patient care. And so very, very frustrating and really unprecedented, considering that United had touted the fact that it was moving away from prior authorization for physical therapy as of last year. This is in Medicare Advantage, and there's been a whole bunch of information showing that prior authorization is overutilized in Medicare Advantage. So, I think we have the weight of evidence and the weight of momentum on our side to try to push back on this. I think it's achievable that we at least delay and then hopefully rescind this policy, just like we did with the time in and time out shift, where we got some more clear definitions about what that entailed. I'd finally say that in terms of the fee schedule, going back to that, there will be opportunities for comment for folks. We're going to make sure that folks can comment both on the overall cut, as well as an opportunity to focus on the quality measures and the value-based care components of the fee schedule. So writing those comments, there will be comments available beyond the APTA draft letter that folks are going to be able to modify and use. And just a lot happening in August. It is sort of an unusually busy time. We are often responding to the fee schedule around this time, but really hope folks engage and let folks at CMS know what the perspective is of folks in practice. At physical therapists really have an important voice, and it's important for patients really that voice be heard and expressed with CMS and then also with the Hill. So that's the update from DC and the regulatory world, as well as with UnitedHealthcare. We'll keep you apprised of other changes, and hopefully we'll see some successes, just like we saw in the initial publication of the fee schedule, in the final rule, and then also with the UnitedHealthcare policy. So stay tuned, but that's where we are right now.